Thank you for joining me today. In this video, you will learn depressive disorder and suicidal ideation for children and teenagers and early childhood. And it is neurodevelopmental disorder. Depressive disorder and suicidal in children and teenagers. Depressive disorder in a youth present with mood, behavior, cognitive, and somatic symptoms. Children often show irritability rather than sadness. So when the children depressed, they show irritability instead of sadness. Depression in adulthood, it shows sadness, but in children, they get irritated. Depression is a major risk factor for suicidal ideation, which is the leading cause of death in teenagers. So please seek a medical attention and talk to your provider if you have those symptoms. This video is educational only and is not replace of trained medical and provider advice. I am not your doctor, so please contact your doctor if you have any of these symptoms in this video. Early identification and treatment are crucial and life-saving. So common depression disorder in youth include major depression disorder, that continues 2 weeks or more of a depressed or irritability mood or loss of interest in a pleasure activity. Plus 4 additional symptoms or greater. For these symptoms include sleep disturbance, appetite and weight changes, fatigue. So appetite and weight changes, some people, their appetite decreased and they don't want to eat and they experience weight loss for some of the children. And some of the children may have increased appetite and weight gain. They experience fatigue. They experience poor concentration. They feel guilty and worseness. Psychomotor changes. They experience recurrent thoughts of hurting themselves or others. Causes functional impairment. In a children, the symptoms are irritability, may lead or replace the sadness. So the children are more irritable, hard for them to sleep, eating changes. Persistent depressive disorder, dysrhythmia, is a chronic depression or irritability mood that lasts 1 year or more in a children and teenager, mild but more long-lasting than major depression disorder. Disruptive mood dysregulation disorder, is a severe temper outburst plus persistent irritability. Onset is before 10 years old. This regulation from episode of a depression, and it is this thing is different from depression. Clinical presentation in children and teenagers is irritability. So depression presents irritability, anger. They refuse the school and they have a decline of school activity. Somatic complaints like headache, stomach ache, they will complain those symptoms. Social withdrawal, they have a social withdrawal. Risk-taking behavior, especially teenagers, they have a risky-taking behaviors, so they are impulsive. Substance abuse for teenagers. So the risk factors for depression and suicidal ideation include family history of mood disorder, trauma, abuse, bullying, academic or peer difficulty, if they have any difficulty for academic, and if they have peer difficulty, if they have a difficulty with the people who are their age, if they have any difficulty in school or academic setting. Substance abuse can cause depression. Chronic mental illness are the risk factors. Prior suicidal attempt, strongly predictable. Suicidal in children and teenagers. Warning signs include talking or writing about sadness, expression of hopelessness, worthlessness, giving away proportion, sudden mood improvement after depression, social withdrawal, increased risk of taking or talking. So what is the assessment? Assessment is always assess suicidal ideation and in a depression in youth. Ask it directly about if they have a plan, if they have intention, use developmental approach language, correlate with categories, and school is essential. Talking to the school is essential. Providing a support. So the treatment and intervention include psychotherapy is the first line for mild to moderate depression. Cognitive behavior therapy is the second. Strong evidence-based target negative thoughts, pattern and behavior. Interpersonal therapy focus on a relationship and role transition. Pharmacology treatment indications. If the child having a moderate to severe depression, pharmacology therapy is indicated. Failure of a psychotherapy alone is indicated. Significant functional impairment. When there is a significant functional impairment, pharmacological therapy is indicated. Failure of a psychotherapy alone indicates the pharmacology treatment. First line of a pharmacology treatment is SSRIs. Fluoxetine is approved for children older than 8. Children 8 years and older, fluoxetine is approved for these children. Escitalopram, FDA is approved teenagers. Start low and go slow. Start the lowest dose and see how the children mood improves and how they tolerate with the symptoms or the side effects. There is a black box warning on these medications. They increase risk of suicidal thoughts in early treatment, require close monitoring, not evidence-based. They are not evidence-based, they require monitoring, they increase the risk and depression symptoms. Combined treatment include cognitive behavior therapy with SSRIs are the best outcome for moderate and severe depression. Superior to either alone. Suicidal specific interventions include immediate safety measures, remove access, mostly preferable is inpatient hospitalization. Safety plan, warning signs, coping strategy, contacts, increase supervision, hospitalization, active and plan needs hospitalization, inability to ensure safety needs hospitalization, family involvement, psychoeducation. You want to educate the family and the patient. You want to monitor the symptoms and treatment progress, support and communication training. School and community interventions include school counseling, academic accommodation, anti-bully intervention, community and mental health support. Progressive and prognosis. Most children improve with appropriate treatment. Recurrent is a common. Early onset increased risk of adulthood mood disorders. Ongoing follow-up. They need ongoing follow-up is important. Differential diagnosis include ADHD. These children may have ADHD. They may have bipolar disorder. They may have grieving or going through grieving phase. They may using substance-induced psychosis or irritation. So irritability is a depression sign in a children. Always assess the suicidal risk. Cognitive therapy is the first line for mild cases. Fluoxetine is the first line of treatment and is SSRIs. Monitor closely after starting the antidepressant medication. Prior attempt, strongly suicidal precaution. Thank you for joining me today in this video, and I would love to see you in my next video. Take care. Thank you.